5 minutes.
Thank you, Mr. Chairman, and thank you to our witnesses for sharing your time today. I appreciate the testimony and your insight, and I think the urgency cannot be overstated. And yet, we want to build on what we know works, and we want to do what we can to eliminate that which we know does not work. I get a little concerned, when the term fraud that we should all be concerned about is often used to describe what might have been an innocent mistake amidst a bureaucracy and piles of paperwork, and we don't want the heavy hand of government to overreact. But I'm curious to know what you might have to suggest about states coming up with innovative solutions. One thing we do know is that with our 50 states, they're different among themselves. I know that representing rural Nebraska, the definition of rural has a different application in different parts of the country. And so if you might, any of you, elaborate on perhaps how we could maybe rely on states for innovation and incentives to increase the effectiveness of care and access. Not all at once, but go ahead.
States obviously have a very strong fiscal interest in this question because, of course, they're responsible for about 42% of the cost of the Medicaid program. The Medicaid program, many Medicaid people are essentially young, relatively healthy people, but the older Medicaid beneficiaries are among the sickest and among the most expensive patients that we have. Many of them are dual eligibles in Medicare. And so the states are very concerned about improving delivery of health care. I think in terms of rural America, the idea of being able to bring modern electronics out there where if you can't get a doctor, let's get somebody who's trained at the local level and have communications back with a medical center. In addition, states are rushing to do this, but increasingly we're going to need to look at with the personnel who provide healthcare services. We're going to have a doctor shortage. There's no question about that. We're going to have a lot more people who will be demanding care. We're not going to be producing that many more physicians because it takes so long to produce a physician, a good physician. So we're going to have to look at expanding the scope of practice for nurse practitioners, for example, physician's assistants. States control that. They need to take a look at that issue.
Okay. Ms. Ridlin?
I would agree with that. It's the Medicaid program which you ought to look to for giving states the most flexibility, and the potential is there. The situation now with waivers is much too complex, and it would be important, I think, to provide a more uniform system where states can do take the measures that they think are most cost effective and are rewarded for that, but don't have to go through a very complicated waiver process.
Mr. Baker?
I would agree. I think some of the experimentation that's happening under the ACA, but also outside of it with regard to dual eligibles, people that are eligible for both Medicare and Medicaid. And there the states really are pushing the envelope in many instances in combining those funding streams and coming up with creative ways to manage the care. The typical statistic is these are the 20% of people that cause, or generate 80% of the costs. If we can control those costs better, much of it through better coordinated care, managing that care better, breaking down those silos, and states have been doing that, and I think we need to continue to encourage that. It's less possible in true rural areas that are sparsely populated, but some of the other ideas around allied professionals getting involved with physicians and others to kind of bring that care to those areas, and also to many times folks don't need that intensive medical care. They need kind of social supports or other supports, kind of live in their communities and stay healthy, and I think those are important initiatives that states are engaged in right now.
Okay. And Mr. Baker, I think you touched briefly on perhaps cost sharing with the emergency room or other areas. Could you elaborate on that?
Well, my point there was that if we increase cost sharing up front, many times people don't access the kind of primary care or preventative care that they need. In many of the proposals, preventive care would be covered first dollar up front, but other primary care would still need a copayment or a deductible to get through. And so what happens is people put off care, end up in emergency rooms or hire more expensive care settings.
Okay, thank you,
Thank
Mr.
you.
Chairman. Thank you, Mr. Kynes, Director.